Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Practicing clinicians recognize that each patient with obstructive sleep apnea is a little different. We know some of our patients have positional OSA, others state-dependent OSA, some have more prominent hypoxemia than others, some are obese, while others have maxillofacial anomalies. But apart from these obvious clinical differences, there is increasing interest in different pathophysiologic subtypes. So to discuss this evolving field, my guest today is Dr. Timothy Morgenthaler, a board-certified sleep specialist and professor of medicine at the Mayo Clinic in Rochester, Minnesota. Tim, welcome. The basic predisposing factor to obstructive sleep apnea is obviously anatomic with compromise of the pharyngeal anatomy. However, three additional pathophysiologies have been identified. They're often called endotypes, and they may result in different clinical manifestations and perhaps in different approaches to treatment. These are a low respiratory arousal threshold, reduced pharyngeal neuromuscular responsiveness, and an oversensitive ventilator control system, also called high gain. And interestingly, it appears that about a third of OSA patients have each of these endotypes. For clinicians like me who are not grounded in respiratory physiology, these concepts can be challenging. But they seem to be increasingly important in understanding OSA and its treatment, and I think we should try discuss them and help our listeners get a better grasp from them. But to make this clearer, I would like to ground the discussion today in clinical cases to make it relevant and hopefully more understanding to all of us. So let's start by considering a patient with an AHI, a typical patient, an AHI of 25, and a respiratory arousal index very close to that of 23 per hour. Despite the high AHI and the high arousal index, the minimum saturation is only 89%, and many of the arousals occur without desaturations below 90%. So what pathophysiology might be dominant here, and how might this affect treatment?
Wow. Well, thank you, Michael, for first of all having me on your podcast, and second of all for introducing such a very interesting topic. As you've explained, these endotypes are essentially subtypes of a condition. I mean, you could talk about anything, each defined by sort of their distinct physiological function or biological mechanism. I think we can all recognize that from the wide variety of clinical presentations and the response to therapy, that obstructive sleep apnea very likely isn't just one homogeneous disease. And as I was thinking about this, and I knew you were going to ask me about this, I was thinking of something maybe that we've often thought of in an analogous way. If some of us go back to our very earliest days of medical school, we learned about lymphoma. And way before my time, lymphoma was just one thing. And by the time I was in medical school, maybe they had a few subtypes. But we now know that lymphoma has many, many different subtypes and endotypes, and it's extremely important to know the difference because the variations in prognosis and the type of treatments that work is so closely linked to that. And I think we're on the brink of a similar advancement in our understanding and personalization of therapy for obstructive sleep apnea. So learning about these endotypes is very important, and I think it will help us tailor treatment. So my understanding about these endotypes at this time, I'm going to actually say there's four, but you've already covered one of them. Is basic mechanism is the compromised or collapsible upper airway. Some of the literature talks about that as being part of the endotypes. And then second, as you say, ventilatory control instability or loop gain. And this really reflects an overly sensitive respiratory control system that can react too strongly to changes in either oxygen or carbon dioxide levels. This instability can create these cycles of sort of overcorrection and then undercorrection and destabilized breathing. The third that you've mentioned is a low respiratory arousal threshold, and people with this trait wake up very easily in response to breathing disturbances. And while those arousals are nice because they restore airflow, they also fragment sleep, and they don't necessarily address the underlying condition or obstruction. And then finally, there's that ineffective upper airway muscle compensation. And in these cases, the muscles that would normally help to keep the airway open don't fully activate or activate as much as they ought to during sleep. So this characterization or this scheme will really prove most useful if, first of all, we can recognize them. And you're bringing up that very good point. They can be difficult. If we can't recognize them, they're not of much practical help. Second of all, we have to be able to modify them. And when we modify them, they must have an impact on the patient's outcomes. So that's a bit of a fly in the ointment of this whole scheme, because truly determining the endotypes, at least currently, requires advanced processing of signals from a polysomnogram. And that's something that can be done now with special software. And that software is actually available open source, but it's not integrated into the systems that most of us use in daily practice. So now I'm going to come back to your case, because you asked me a good question. In your case, I think the high ratio of the respiratory arousals to respiratory events probably indicates that this patient has a low arousal threshold. And if I were looking at their sleep study, I might expect that these respiratory events would be short and that this person would have a lot of N1 sleep. That can also be suggestive of this trait. Most sleep studies in individuals who are identified with this endotype do show the very modest drops in oxygen saturation, like the one that you mentioned. And so I think that these things are supportive of the idea that this patient has a low arousal threshold. So what does that matter? Well, some studies have indicated that patients with low arousal threshold have worse problems complying with CPAP, worse initial compliance, and over time, their compliance sort of deteriorates. These patients often don't experience significant improvements in their sleep quality by polysomnographic criteria like arousal, frequency, and so forth, and that may limit somewhat their symptom relief. And so therefore, if you do start CPAP on a patient like this, doesn't mean that you can't try that, but I think they're going to require very much closer follow-up and increased attention to comfort maybe than the run-of-the-mill. And then there is some evidence to suggest that patients with this low arousal threshold, they may respond a little bit better to oral appliances. The literature on that, from what I can glean, is a little mixed, but it might be something worth trying, particularly if the protrusion isn't too much or too uncomfortable. And then additionally, some people are thinking about combination therapy, where you add medications like azapiclone or trazodone especially, which can raise the arousal threshold. These may prove beneficial. Now, I think the studies on these approaches have produced both positive and negative results, but I do think that as more studies are done and they're more careful in identifying this endotype, that these may prove helpful.
Excellent. Well, let's consider another patient, very similar superficially, also has an AHI of 25, but in this case, the respiratory arousal index is only 7 per hour. The respiratory events are fairly long, and saturations routinely drop into the 70s with many of these events. What might be happening here? If the patient didn't tolerate CPAP, what are the alternatives here?
Well, this is challenging. The low arousal index, despite these very low desaturations, first of all, suggests this patient does not have a low arousal threshold. They have a high arousal threshold. It's hard to get this person to move off of the challenge, so they don't wake up very easily to these obstructive events. Usually, patients with high airway collapsibility as really a dominating phenotype have more severe sleep apnea than this patient does. So, I mean, we can assume everyone has some upper airway differences, but I think in this patient, probably it's not the main driver. You haven't mentioned anything in this patient about cycling instability or a high number of central or mixed apneas. So I'm not thinking of loop gain as a high loop gain as the problem. Probably this patient has reduced muscle responsiveness as the underlying phenotype. And I think this would be particularly likely if there were a high proportion of hypopneas in the AHI. Oftentimes these patients try to mount a response, but they don't quite make it over the hill, so to speak, and eliminate the obstruction. So, although I can't be certain, I think this patient might do well with CPAP or an oral appliance. But if that did not work out, they could be, I think, evaluated for perhaps hypoglossal nerve stimulation therapy. And if it comes available in routine clinical usage, it might be a good case for using a non-adrenergic or muscarinic agent like atomoxetine oxybutynin, which can increase that pharyngeal muscle activity. Now, this latter agent is being published and spoken about at meetings, but I don't think we've had it FDA approved, and its rightful place in the toolbox will still have to be worked out.
Great. All right. Well, let me challenge you with another patient with an AHI of 25. Most events are obstructive, but you note that after arousals from many of these events, a more central appearing apnea develops as they're drifting back into sleep. So you do a split night study. The second half, you put the patient on CPAP, and straight away central apneas start developing, and you try find an optimal pressure, but by the time you've eliminated the obstructive apneas, there are central apneas, and you really don't find a very effective pressure. We've all been in that situation. So what pathophysiology might be occurring here, and how might this affect treatment?
Yes, I mean, I think you've described, the patient who very likely has a elevated loop gain, a high loop gain, and they're over-responding, and then they're then they kind of back away from it. Many of these kinds of patients, like the one you've described, develop what has been called treatment-emergent central sleep apnea when their airway obstruction is alleviated, whether it's with CPAP or oral appliances or other things. And I think in one of your prior podcasts, we talked about how maybe a third or even a half of these will resolve with time or come to some acceptable level, but some remain very poorly treated with just airway opening therapy. And I think in these cases, adaptive servoventilation can certainly be helpful. There are some evolving alternatives to servoventilation. I'm not sure how practical they are in each patient, but adding pharmaceutical agents such as acetazolamide or even atomoxetine oxybutynin, both of these have been shown to lower the loop gain. So these may play a role, maybe some airway opening therapy plus these medications, or maybe even some cases, this sort of therapy alone. And I would just mention also that supplemental oxygen in combination with airway opening therapies like CPAP has been used as a way to lower loop gain and bring them into some control, at least as far as their airway goes. So I think the patient you've described had a high loop gain.
Very, very helpful to think of it in those terms, a little different from the way we just say treatment emergent central. I really like thinking about the pathophysiology. Well, let's go to something a little different here. The next scenario is a patient who appears to have mild OSA, AHI of 7. But when you look at it in more detail, all the events are occurring in REM sleep with a REM AHI of 30 and desaturations in REM sleep down to 75%. Do we understand what underlies this particular phenotype? And is this mild OSA or is it severe OSA?
This has been debated for a very long time. You've given me a tough one here. I think it is often very challenging to see what the specific endotype is, just from the clinically available data. Now, the studies have shown, though, that patients with significant REM predominance may have greater problems with airway collapsibility or maybe less responsiveness. And so that may be sort of the endotype that we're exploring. I think future studies are going to be needed to further clarify that, or maybe we'll someday soon have software right in our systems that can help us know. I think addressing your query about the severity of the condition is also very challenging because I think it depends on our definition of severity, right? I mean, traditionally, we think about severity by the frequency of apneas and hypopneas, which is just a convenient way, but doesn't necessarily correlate all that well with long-term complications or the effects on health. And I think there's increasing awareness that, counting apneas and hypopneas may not be as useful in terms of that. REM predominant OSA generally does present with a higher hypoxic burden, and this is something that is increasingly measured and talked about, and that can lead to more severe cardiovascular and metabolic complications. as well as, cognitive problems and mood changes and all these. So these kind of distinctions, I think, highlight the importance of considering hypoxic burden and sleep architecture when you're thinking about managing patients. So is this mild, moderate, or severe? I think, again, it depends on how we categorize it. Maybe we ought to consider this patient, even though by the numbers, most of us say they have moderately severe sleep apnea. Boy, with that hypoxic burden and the REM predominant kind of phenotype, if you will, perhaps they have more severe sleep apnea than we would otherwise think.
Very helpful. All right, one more challenge. Two patients with the same AHI, again, let's go back to 25 an hour, and similar desaturations, very similar. But the one patient is profoundly sleepy, dozing at their desk, falling asleep at the wheel, while the other one absolutely denies any sleepiness at all. Epworth Sleepiness Scale of 3, I never fall asleep. I don't believe I've got sleep apnea. Do we have any idea why some patients with the same apparent disease complain of sleepiness and others don't? Is there any difference in long-term prognosis of these two groups?
Yeah, this is always so interesting when we see these in the clinic, aren't they? I mean, you see two people, one maybe with a low AHI who's very symptomatic, and the other with a high AHI who really hasn't a complaint in the world. I think now you've shifted our discussion here from endotypes to what many people talk about as phenotypes, which is a little different. These are distinct subgroups within this this non-homogeneous disease that researchers have been really identifying using sophisticated statistical tools to look at not so much the physiology, but the symptoms, comorbidity, some of the polysomnographic findings, craniofacial features, even lifestyle features. And they're usually applying these statistical tools to quite large databases like national registries and global registries of sleep apnea. And by analyzing these, I think there have been several studies that have come up with three sort of recurring phenotypes, one of which your candidate patient has. So here's the three phenotypes. First, there's the sleepy phenotype. These are the patients who really are, falling asleep over their desk during the day. These sleepy patients do seem to have a different prognosis. Most of the cardiovascular risks seem to reside in the sleepy phenotype group here. And they typically respond well to CPAP symptomatically, improving sleepiness, and potentially even their cardiovascular health. And some people have been postulating more recently here that had we done some of these large PAP studies that have been a little disappointing in their outcomes over the past decade, had we done those in the group that were only sleepy, we may be seeing quite different outcomes. That's speculative. I think it probably is true, but now we're going to have to wait to do some similar studies with more phenotype patients. The second phenotype that's described is the disrupted sleep phenotype, or disturbed sleep phenotype. And these people, they have more fragmented sleep. A lot of their symptoms are more insomnia-like complaints, and it often makes standard therapies like CPAP a bit more challenging. They really might need additional strategies like cognitive behavioral therapy for insomnia. There may be the COMISA group, a large number of them. They might need dual or multifaceted therapies to see benefits. And the last group is the so-called minimally symptomatic OSA. These patients, they don't report many symptoms because they're not very symptomatic to begin with. It's hard to make them better. So we don't see a lot of symptomatic benefits in therapy, whether it's quality of life or cardiovascular risk reduction. And I think it's pretty unclear how much we assist these patients with our treatments, although it's very hard to look at an AHI of 25 and maybe some desaturations in somebody who is asymptomatic and think, I'm not going to do anything. But I bet there's going to be some trials. In fact, I know there's some trials that have been proposed looking at this minimally symptomatic OSA group.
Tim, thank you so much. I think this podcast should be required viewing by at least all the sleep fellows everywhere, because I think you've explained it just beautifully. Do you have any final messages to leave with our listeners?
I think I would just give some words of encouragement. Michael, I think this is really an exciting time for sleep medicine. I think just a decade ago, most of us thought about obstructive sleep apnea in a very simplistic way. It's an airway disease. Our approach was largely built on statements like CPAP is the gold standard because it does open the airway. But I think while CPAP has helped many patients, we haven't reached our full potential yet. And I think what we're seeing now is using our data and analytic skills and machine learning to provide new, unique insights into what is the actual reason that these patients are developing the diseases and what are their likely outcomes, and more importantly, what types of treatments might be most personalized to that patient, knowing more about them. So I'm really excited about that. I think, though, we do have a challenge because, this research and using these phenotypes right now is dependent on polysomnography and or more advanced monitoring. And of course, a huge trend in our practices are to get more and more simplistic tools that have less and less burden on the patient. And so, we're going to need to figure out how to squeeze more information out of less monitoring. And that's going to be a challenge, but I think we're up to it. And so I'm very encouraged at the fact that we're thinking about these things differently and that we're doing the work to get us to better care for patients.
Thank you so much. We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.